I want to thank you all for being here this morning, and I want to thank the NASSPD board for inviting me to give this talk and for this opportunity. When asked to do this talk, I thought about sort of my experiences in teaching TFP, transference focused psychotherapy. People can hear me okay? Okay. Teaching transference focused psychotherapy at a graduate program for clinical psychology doctoral students over the last 14 years. And teaching treatments for, psychotherapy treatments for borderline personality disorder, I think is challenging. Teaching any psychotherapy is challenging. It's complex and there's a lot of nuance. Teaching to clinical psychology doctoral students, people coming in often from undergraduate with very little experience, has also created some unique challenges. And one of the things that I've tried to do is figure out how to actually reduce that complexity so that what we're teaching is palatable and understandable to the students, but without losing the nuance, the subtlety, or the complexity of what we do. Most of the students I teach, the way our program works, my clinical program is it's a top 20 to 25 clinical program, mentor-based admissions, so people come to work with specific faculty. People who come to work with me know my work and know what I do and sort of take to it, but I'm one of 18 faculty members. There's lots of people coming in who haven't necessarily heard of borderline personality disorder, or if they did, they've heard actually that borderline personality disorder doesn't exist, it's not valid, it's unreliable, things that we all sometimes still hear. They know very little about psychodynamic approaches, which transference-focused psychotherapy is. And in American psychology, in the university, psychodynamic approaches is thought somewhere between witchcraft and alchemy. So people come in and they have very biased or distorted views or naive views about what this is about. And I've worked over the last 14 so years trying to figure out how to actually help people understand what the added value of this approach is. So my talk will be broken up into 4 parts. First, I'm going to give you a little bit of context, which I've already gone into. Then I'm going to present the psychotherapy, transference-focused psychotherapy, in a way that I hope will resonate and convey the important aspects of it. And then I'll present some data that's consistent with the way that we think about transference-focused psychotherapy. And then finally, I'm going to make a plea for pluralism. And then hopefully I can do this with enough time for questions. I actually can't see the presentation on the screen here. So that way I don't have to, still can't. This comes under the heading of Best Laid Plans of Mice and Men. I got here at 8 o'clock to get all this set up. Couldn't even actually cross the road, had to go all the way around. Yeah, then they wouldn't let us into the building, you know. Then Anthony had to go first and get his slides up, wherever he is this. Yeah, okay, here we are. Okay, still not. Okay, well, So I went in a little bit of this context already. In sort of teaching psychotherapy to graduate students, at the very least, I want the students to understand that borderline personality disorder exists, that it's a valid disorder, that it could be reliably identified. And I want them to be in a position that they understand that there are multiple psychotherapies available to patients with borderline personality disorder, although they're learning a particular one at that time. And most of the people that I'll train, unless they're one of my students, typically will actually not go on to learn TFP. They'll just be sort of TFP aware and maybe TFP friendly in the future. And most of our students actually go on to other academic training programs across the country. So our program is in the top 10 in sort of producing academics that go on to teach in clinical psychology programs. So I feel like that's actually a win if we can actually increase the pluralism of the next line of faculty. You may not necessarily know this. If you're not a psychology faculty member or in a psychology graduate program, you may not necessarily know this, but the dirty secret about clinical psychology training is that most of the faculty doing the training have actually not seen a patient since their internship. And they tend not to be licensed, and they tend to have very strong ideas about what constitutes psychotherapy, and then it gets farmed out generally to clinicians in the community sometimes, but not always. And so our program is actually rather unique. We actually do all the training in-house, and all our faculty are actually licensed, and most of us are actually practicing. I have a practice that's much more full than my wife likes, that I like, that probably my dean likes too. But it's important because when I train students, I'm often coming from an 8 o'clock appointment with a patient into a 2 o'clock class where I have a lot of clinical material that I can actually share that just happened that morning. Okay. There we go. So this table here actually shows you what the state of affairs are in clinical psychology training programs with regard to training in personality disorders. Oops, I meant to. So the red bar to your left actually represents the number of PhD and PsyD clinical psychology and counseling psychology programs in the United States. There's 319 of them. If you look to your right, the right set of bars, what you'll see is the green bar that's very low represents the number of faculty members across these 319 programs, or a number of programs, I should say, across these 319 that actually have a faculty member who studies personality disorders. The number is 24 out of 319. The yellow bar actually represents the number of clinical psychology programs that actually have a specialty clinic for treating patients with borderline personality disorder or personality disorders. It's 7 out of 319. On your left-hand side is actually a comparison for panic disorder. And so 319 programs, but many more faculty. Many of the programs actually have 2 or 3 faculty who actually treat panic disorder or other anxiety disorders. I was talking to Carla last night. She told me they have 7 faculty at the University of Houston that study anxiety disorders. And then the yellow represents the number of specialty clinics in panic disorder at American psychology programs. This slide actually shows the comparison to the prevalence. So the red bar now represents not the number of programs, but the prevalence of the disorder. And you can see that the number of faculty who have expertise in panic disorder versus personality disorder, and the number of specialty clinics that exist in terms of treating panic disorder versus personality disorder is inverse to the prevalence. And so something's really actually quite wrong. We should have many more faculty and training and specialty clinics for personality disorders compared to panic disorder, given the prevalence. And one might argue, given the seriousness of the disorder. Pardon? Oh, sorry. I tend to be one of those talkers that move. I guess I feel imposed upon now. Sorry. Okay. I will try to stay put. Now, in psychiatry residency programs, there was a study by Gerald Kay and colleagues. They actually sent out interviews to surveys to 190 residency programs. Only about less than half actually responded, and less than half of those that actually responded actually have a didactic course on personality disorders, representing 10 hours of 10 hours of total training, usually during the second year of the PGY2 year. The other 50+% actually had about almost 3 hours of teaching on personality disorders. And they reported the percentage of programs that actually trained their students in DBT, TFP, MBT, and other treatments. It was a little bit hard from the write-up to actually discern whether that 89% represented the 89% of the 43% of the programs, or if it was 89% of the 45% of the 43% of the programs, which would, and it's why I put in parentheses the number with a slash, if you look at TFP, we were pleasantly surprised to see that half of the respondents that teach about personality disorders actually teach TFP. If that's true, it's 23 programs around the country. I can name 7 off the top of my head. Maybe Frank and Eve could name the rest, but regardless, it's a relatively small amount. I mean, it represents 10 to 20% of the programs teaching TFP and about twice that teaching DBT. And of course, we don't know exactly what that means in terms of how involved that teaching is, you know, how much exposure they're actually getting. My students, for instance, take a full year of training with me, and most of my students will not be able to actually practice TFP after that full year. They are in a position now to get additional supervision and training. Our program's set up to do that so that people could come out after 3-4 years possibly being competent enough to practice TFP, but it's not a given. And I imagine the same thing is true in these residency programs. And so we're really just scratching the surface. Now, the good news is that there are a number of empirically supported psychotherapies for borderline personality disorder. I don't think that this is necessarily an exhaustive list. I sort of arrayed it by CBT-based and psychodynamic-based programs, but all these psychotherapies tend to be modified from traditional CBT or traditional psychodynamic therapy, and also tend to be integrative and have a lot of shared properties, even though, as we've heard over the last couple of days, there are obviously big differences, too, in the way that they are actually presented. And there's been a number of meta-analyses now that have looked at the various psychotherapies, and they find a really consistent finding that's, I think, starting to permeate the PD world, which is that there are no differences between the treatments. And here are 4 major meta-analyses that essentially have found that. The most recent is the Christie et al. Study that was published in JAMA Psychiatry. And you can see here in the little box, 33 trials, over 2,000 patients. Effect sizes were small to moderate. No differences between DBT and psychodynamic treatments. No differences in dropouts. While the effect sizes are on the small to moderate side, they're still actually very meaningful clinically in communities. It means that if you translate these effect sizes into a number needed to be treated, it's about 5 to 7 patients coming into a practice. One of those patients will actually improve compared to people out in the community. It doesn't sound like a lot, but if you think about each community and how many people exist with borderline personality disorder, when I gave a talk in Boston, I think I actually estimated that there was something like 400,000 borderline patients in the Boston area if you went from prevalence rates. With New York, it's probably even more than that. So there's a lot of people who are in need of help, and if you think about the fact that even a small number of people will be helped, that's important. This data is it's consistent with all the other meta-analyses, including this one here that I'll show, which was actually done by DBT researchers looking specifically at DBT. And the important point here is they found actually very similar effect sizes in terms in the moderate range when you compare DBT to treatment as usual. But when compared to an active treatment, there was no difference in effect size. It was 0.01. And so we have very good evidence that none of the treatments are actually, that despite what the adherence to a particular approach might say, none of those treatments are actually better than the other, at least by our standards today in terms of how we measure outcome and so forth. Now, maybe we'll find differences. My colleagues and I, Bill Ellison, Christina Temis are in the audience, did a meta-analysis too. We found the same exact kind of finding. We took a different approach, and we had more studies, a broader approach. This is just focusing on the RCTs, but you can see that there's really no difference in the effect size here either. And we looked at the quality of the psychotherapy studies, because one knock against psychodynamic psychotherapy is often that this idea of poorly done research. But we couldn't find any differences in the quality of the studies using multiple measures of quality, blindly rated. Bill blinded all the studies, and they were coded by an internal coder and an external coder who were reliable. And the external coder was completely blind to everything going on, even to BPD research, although she was a psychotherapy researcher. And then we correlated our scores with scores that were posted from an American Journal of Psychiatry article where there was overlap in some of the studies, and our ratings correlated 0.91. So we feel pretty confident that these aren't necessarily biased estimates here. Okay. So what is transference-focused psychotherapy? Some people here may know a lot about it. Some people may have heard it bandied. But what I want to do is explain a little bit about transference-focused psychotherapy. So transference-focused psychotherapy, as I say here, is a modified psychodynamic treatment. It's based on Otto Kernberg's object relations model. And it's a manualized, intensive treatment. I say intensive because it's designed to be twice a week for at least a year, typically multiple years. Typically done outpatient, evidence-based, number of efficacy studies, and as we see in the meta-analyses, no difference in effect size. And TFP, I think at this point, would be considered one of the big 5 psychotherapies for treating borderline personality disorder. The others being obviously dialectical behavior therapy, mentalization-based therapy, schema-focused therapy, and GPM, and is on a number of guidelines and with regard to treatment of borderline personality disorder. It's not nearly as disseminated, I would say, as DBT for sure, or even MBT at this point. So the goals of TFP will, I think, sound quite similar to the goals of other psychotherapies for borderline personality disorder. Essentially, better behavioral control, increased affect regulation, more intimate and gratifying relationships, the ability to achieve satisfactory, and more recently we're sort of stressing the realistic life goals that are consistent with one's capacities and interests. We don't want people to be underemployed, for instance. We want people to be employed at the level that's consistent with their intelligence and what they want to do. And so we have very specific goals of reducing the symptoms that are associated with borderline personality disorder, including suicidality, parasuicidality, impulsive hostility, angry outbursts, etc. And we want to see fewer emergency room visits, hospitalizations, and relationship difficulties. And from a TFP perspective, we believe that this all occurs through the integration of disparate and incoherent internal representations of oneself and other, what we refer to as identity, or the resolution of these problems as identity consolidation. And this is going to be an important point and emphasis in TFP. Okay. And the developmental model, simply, I won't go through this in great detail, but the developmental model is essentially that these complex, realistic internal representations don't develop in individuals with borderline personality disorder, probably from a host of factors. I realize I'm walking away from the mic, sorry if you couldn't hear. Probably from a host of factors, including temperamental biases, and that these fragmented representations actually leave the person unable to sort of think in ways that allow them to regulate their affect. And this way of thinking is actually very consistent with what identity disturbance in the DSM-5 and previous, and also in the Section 3 of the DSM. Okay. And so what the therapist does is works on helping the patient develop these integrated representation so they can think of themselves and others in more benevolent ways, and have better control of their affect and less aggression infused in relationships. I hope you're doing that for later, right?
Yes.
Okay, good. It says 5 minutes. I was like, okay, thanks. Yeah. Okay, so, and we do this by exploring and observing the patient in relation to us during the therapy sessions. And there's a particular reason why we actually focus on what's happening in the here and now with the patient in the therapy room. Ironically, not so different than functional analysis from a behavioral perspective, because we actually are aware of what's actually happening in the room in terms of the interpersonal dynamics. This is not based on, for instance, hearsay about what happened in other relationships that we may or may not be able to actually discern. So how do we do that? Well, we start with a very intensive assessment process before we actually start the psychotherapy. And in gathering the information during that assessment process, we work to collaboratively set a frame with the patient. And this is being very explicit and, about what the roles and responsibilities of the patients are and our roles and responsibility and how things are handled in treatment, making predictions about difficulties that might arise in the treatment based on understanding their treatment history, discussion of possible secondary gain, our diagnostic impressions. We share our diagnostic understanding with the patient and the rationale for treatment. And so what we're doing is making very clear, but this is done in a collaborative way. This is often referred, and people may have heard this referred to as setting a treatment contract. I find that when I present, so Otto usually when he's presenting, he's going to psychoanalytic institutes that have invited him to talk about TFP. In some ways it's kind of like preaching to the converted. Often when I go and I give talks, I'm actually giving talks in psychology departments and psychiatry departments that are very cognitive behaviorally oriented. We have DBT programs. Students I train, I find that using the word contract is a big distraction. People start thinking about lawyers and whether their lawyers are going to get raided, or so I need to get this notarized. They start thinking about things like that, and it just becomes a big distraction. But I find if I say frame, everyone's on the page. They understand what setting a frame actually means. And so I talk about it in terms of setting a frame, and I stress the collaborative part because it's not an imposition of our beliefs onto the patient only. There is some of that. We do have expertise and we have knowledge and we want to convey what we believe, but it is actually a back and forth exchange with the patient because they have knowledge of themselves, and we collaboratively come to a frame that we can live with. We're not acquiescing in setting the frame. Oh, well, what do you want to do in therapy? But we don't want the patient to acquiesce either, because that's not really a collaboration or an agreement. And so we work towards this collaboratively set frame. But we know full well, because the patient has borderline personality disorder, they may forget what we've discussed. And we see that as part of identity diffusion. When you talk to people that are identity diffused, they say one thing 1 minute, and they might say another thing another minute. And and even though you just had a conversation. So we may have a patient who agrees with us that on our understanding of borderline personality disorder as the core of their difficulties. We think, great, they leave, they come back the next session, it's like they have bipolar disorder. And I'm sure we've all had that experience. So we recognize that that's part of this, but having had these conversations, we can refer back to them and work that through. We also take what I call a non-judgmental stance. This is my way of referring to what in TFP we call techno-neutrality, which is also a phrase that is weighed down with huge amounts of baggage. Kernberg actually used techno-neutrality to distinguish it from neutrality, trying to sort of move it away from sort of these stereotypical conceptualizations of psychoanalytic therapists who, sort of are blank slates and don't convey any information, aren't warm or anything like that. But I still find that when I present it, either people don't understand it because they come from a different perspective, or it comes with the baggage. But if I call it a non-judgmental stance, where one's trying to be equidistant to all aspects of the patient's sides or conflicts, then it resonates better with people and they understand it. And really the goal of this non-judgmental stance is an empathic stance. and I often convey to my students something that I heard Otto say, although in writing a chapter for Uli's book, we had a hard time finding it in print. But I've heard Otto say this, that true empathy is the capacity to empathize with all aspects of the patient's experience, even those aspects that the patient themselves cannot tolerate. And this is what we're doing by taking this technically neutral or non-judgmental stance. And the reason we do this is so that all aspects of the patient's experience can come into the therapy and be discussed. And that means the things that they're not happy with in their life that they may avoid in session, but is actually what got them where they are, so to speak. And so we don't sort of shy away from those things. Now, in doing that, we pay attention to what are called the channels of communication, or 3 channels of communication. I find that that's not necessarily a metaphor that's distracting to people, although channels on a TV are probably, if you think of it as YouTube channels, that works maybe, right? But yeah, TV, what's that? But different channels of communication, what the patient says. What they say at one moment, what they say at another moment, it could be congruent, it could be discordant. What the patient's affect and behavior are, is it congruent with what they're saying? What's evoked in you as a person sitting across from this patient? This we refer to as countertransference, which that's a whole can of worms. When I use the phrase countertransference in a psychology department, people have really strong countertransferential reactions to it. And so I find I can't say that. What I say instead is, what gets evoked in you as a person sitting across from another person. It's wordy, but it's experienced near, and people understand it. Everyone has had the experience of sitting across from a patient and having something evoked in them, and they understand that. And that's really what we're paying attention to. The way Otto talked about it is, we use ourselves as a barometer for, what's happening interpersonally, and how does that fit with what's being said, and how does that fit with the affect. And an example, just recently I had a supervisee has a patient who comes in, you watch this on tape, and we were able to do it in slow motion, it was really interesting too, comes in, sits down, and tells the therapist, I almost didn't make it here, I've been having a horrible week, and I had a pseudo-seizure, she called it a pseudo-seizure, which we thought was interesting, and she said all this with a big smile on her face. And that was the opening volley of the therapy. And a transference-focused psychotherapy therapist is not just listening to the words, which if you heard without the affect, would actually convey one thing to you. We're also paying attention to the affect, and we're trying to integrate all that in. We watched it on video. You could actually see the person starting to smile in anticipation of the therapist ending sort of the paperwork component. Like she was getting up for this. And, and then she shares this with him, and rather than being concerned that she had a pseudo-seizure and she's having a bad week and all this, her affect was actually quite to the contrary. And we find this a lot, and this actually helps us have actually very powerful moments with the patient if you can bring it gently into their awareness in a way that doesn't feel like an imposition or a challenge or an attack. And so there's a lot of subtlety in sort of how to do this that we're trying to convey. And then we engage in this interpretive process here. And interpretation is also sort of a phrase that has some baggage with it. I've been trying to think of other ways of describing it. I thought about, essentially this is about trying to understand, and I thought that this is really about meaning making, and I guess you can't get away from this, and this is where TFP is different than some other treatments, that there's some motivation. And the example I just gave actually leads us to sort of describe, exploring what that motivation might be. So, you're telling us about having a bad week. I'm not sure if you're aware of it, but I noticed, maybe I'm wrong about this, but it seemed as if you had a smile on your face that was developing as you were telling me this. And I wonder if we could sort of think about what, why that might be. And that gets at the motivational component. And so it's not simply, excuse my language, a shit happens theory of borderline personality disorder, that you have borderline personality disorder, and who knows why. But we're exploring what the underlying motivations might be for behaving in certain ways, which may be detrimental to the patient, but have some logic, albeit distorted, for them. Okay. We do this process, this interpretive process, through these 3 main techniques here of clarification, what's called confrontation, a phrase I hate, because we don't mean a confrontation like a toe-to-toe confrontation. Here we simply mean something actually quite nice, gently bringing into awareness disparate aspects of the patient's experience, so that they can consider them and integrate them. Stephanie Stepp actually told me I should call this an insight-oriented comment, which bothered me for a little bit, because I was like, as a psychodynamic person, I don't have the luxury of saying that this is insight without being sort of attacked. But she, as a DBT person, could actually call it insight. And I thought, oh, Monica Karski calls it attention-oriented comments, bringing your attention to comments. But essentially what we're doing is we're clarifying the patient's experience. We're bringing into awareness disparate aspects, and then we're making what should be clear, timely, tactful interpretations. Now, we do this from coming in and actually paying attention to what the dominant affect is, like in the description I gave you earlier, where we see the affect in the patient. And then we will clarify and, for lack of a better way of saying this, confront as we're and clarify more. And in doing this, we will start articulating, explicating the representations that the patient has, and that will lead eventually to the interpretation. And this leading to the interpretation, again, it shouldn't be an imposition or a pronouncement. It's really something that's built up slowly in conjunction with the patient collaboratively, so that it's just in the patient's awareness when you bring it up, and so it doesn't come as a complete shock. I had a supervisor, Ann Applebaum, who used to say a bad interpretation is like going to a cocktail party and having someone walk up to you and tell you something about the thing that you are most bothered about yourself, and then walk away. You'd feel pretty cruddy if somebody did that to you at a cocktail reception or at a banquet like last night. No, it didn't happen to me. Hopefully it didn't happen to you either. But that's not how an interpretation should be done. It's done collaboratively. It builds slowly. It comes into it's just under the patient's awareness, so that when you offer it, it doesn't feel like that giant shock. It's like done as it's a hypothesis testing sort of endeavor. I think I'll skip. I kind of said all this already. I found a slide that I think represents this for me, but you'll see it. Most of you won't recognize this because, and I actually didn't recognize it. I'll tell you this. I heard of it, but you may recognize Orson Welles, and he says, "No interpretation before its time." This is a reference to a commercial that I remember when I was a little boy. I actually misattributed it. It was a wine commercial where they say no wine before its time. They wait to the perfect moment to pick that grape. And if you think about an interpretation like that, I actually thought it was Ernest and Julio Gallo wine. I went on YouTube and looked it up. It turns out it was Paul Masson, not to be mistaken with Jeffrey Masson, wine. And but I do have this memory from my childhood, scary as that looks. But this is a really important sort of concept to have in your mind. This idea of no wine before its time, no interpretation before its time. Have you done the work to actually make the interpretation something that will resonate in the patient's awareness? Okay. So what we're trying to do, putting it slightly into behavioral terms, we're trying to move from experiential avoidance to reflection. And this is a cartoon I often use to illustrate that. It's this man in analysis. He's saying to his analyst, look, call it denial if you like, but I think what goes on in my own personal life is none of my damn business. And that's often how our patients actually come in, right? They come in and they don't want to actually discuss the things that actually brought them to treatment because it's too painful for them to do because they're so critical of themselves. And what we have to do is create an environment where we make it safe for them to actually explore those contents with us, and so that they can actually understand and work on becoming more reflective rather than experientially avoidant. Okay. Say something about the here and now focus. I said this a little bit before, so I'm just going to make one point about this. We do this work in the here and now rather than in the then and there. And we do that because, again, we're there for what's happening in the here and now in the room. So if the patient sees us in a particular way, and we reflect on how we presented to the patient, we can then comment on that. So I once said to a patient, can you tell me more about that? A very simple clarification. And they responded to me in a subtle way in terms of their affect, as if I was accusing them of not believing them, rather than I was a person who actually wanted to understand their perspective. And so I noticed the affect, and I can comment, I have some sense from the way that you're responding to this, and that part of you may recognize that I'm here to help you, but there might be another part that actually may have taken what I said more as a challenge to you rather than wanting to understand your perspective better. And that's how we bring into awareness these disparate aspects that give opportunities for reflection and integration. It's part of the interpersonal process that's happening in the room. Now, sometimes we do focus on the extratransference, and I may talk about that in a bit. This is actually a cartoon that sort of illustrates the difficulties of doing transference-focused psychotherapy work, because you become you become the container for holding their projections. And you have to be able to tolerate. This is the one thing that I can actually, one of a few things that I can often tell with a student whether they're going to actually be able to do TFP, if they can tolerate being the person that the hate's projected onto. Even because look, most of us go into doing psychotherapy because we're nice people, right? We want to help people, and then to go into therapy and have someone attack you and tell you that you're a rotten person and you're doing all these terrible things. Some therapists in training can't really tolerate that. They don't want to do that. But if you can tolerate that, if you can hold these projections, and even we call these therapist-centered comments or interpretations, when we're talking about what's projected onto you, not reinforcing the distortion, but as if you're kind of holding that it's somewhat possible and then exploring that. And so I think this cartoon sums that up a bit. Okay, oops, I keep going to your computer. Really 5 minutes, okay. Really 5 minutes. Okay, what to do here? Let me say something about validation. I think what I'm going to do is I have a whole bunch more slides which I'm not going to be able to present. And you probably don't want to see the ones that I'm not going to present anyway. They're all research oriented and really boring. So we'll skip with that. We'll stay with the clinical material, and this is one difference between TFP and some of the other treatments. We do validation very differently than I think the way it's articulated in DBT and GPM and MBT. We try very hard, I think they do too, to not validate distortions in the patient's representational world. And we do validation through our non-judgmental stance. We do validation through trying to capture the patient's experience with good interpretations. We don't want to create an expectation that might be invalidating. We don't want to reinforce distortions. And we don't actually do a whole lot of reassuring unless we use actually something called part language. And the reason why is that I often have this mantra that I tell my students, which actually a supervisor once said to me, that reassurance isn't always reassuring. Why isn't reassurance always reassuring? Because if you don't believe that about yourself, that what the person's reassuring, you actually think the other person might actually be saying that because they have to. You have to say it, you're a therapist. I won't pay you if you don't say nice things to me. Your supervisor will get mad at you. So you're just saying that. And so reassuring somebody doesn't necessarily reassure them. And so what we do is we bring into their awareness the aspects of their experience that won't necessarily feel reassured by our reassurance. I have a number of examples, but for the sake of time, I won't go into it unless it comes up during a talk. What we do is we use what we call part language to do this. And what part language does is it brings into awareness both aspects of the patient's experience. And we think that this actually works against being invalidating. I'll give you an example. I've seen this 100 times. Patient doesn't show, patient comes in late. Session after session, the therapist is getting frustrated. And what does the therapist say to the patient when they finally come in? They say, I think that you may be having a difficult time coming to therapy. And it seems almost obvious, right? Except it's not the patient's experience. The patient's experience is that they're actually doing heroic things to get into therapy. That's how they got here 20 minutes late. That's how they got here after missing 3 sessions. And so what we do is we try to comment on both sides of those things, both sides of the ambivalence, right? To keep an equidistant there. So we might say, I recognize that, the therapy is very important to you and that you've been, that you get yourself here, albeit late, sometimes after missing many sessions. And so I recognize that part, but I think there might be another part. And then I do this thing where I kind of control how much that part is. I'll say, maybe it's just a little part, but I still think it's something that is worth our examining, this part that's interfering with you getting here, and that's essentially diluting the dose of the work that we're doing together. And I try to talk about it as collaborative work as opposed to an imposition on the patient. This is actually a study that was done in psych science that actually showed that reassurance actually led depressed patients to actually feel worse. Right? This is a core technique in CBT, right? Self-talk and I'm good enough, I can do it, kind of Stuart Smalley stuff. It works for those of us with good self-esteem. If you have good self-esteem, self-talk away, you're going to feel much better. But if you don't have good self-esteem, self-talk is going to make you feel worse. Now, these researchers who were cognitive psychologists and knew nothing about psychotherapy actually had this idea, well, what if we actually acknowledge the ambivalence and then do the self-talk? It had better results. They actually created part language, interestingly. Okay, I'm going to actually skip all this. I'm going to make my, there's so much here. And you see it going by, it's like subliminal. It looks good, though, doesn't it? The good news is we can show that we can actually change these representations in psychotherapy. And we can, I didn't show, but a lot of the research is actually consistent with these models, our model in terms of why identity and representations are important. We see identity as underlying affect dysregulation problems. So the reason why people can't regulate their affect is because they're identity diffuse in the moment. And I'll actually back up to one slide in particular that will show that. This is a study we did, this just came out in JPD in January. This is a smartphone study with a 21-day burst where we followed patients looking at suicidal urges. Patients' affect dysregulation related to suicidal urges, but only in the context of identity diffuse moments. And it makes sense. We all get dysregulated from time to time. I'm actually quite dysregulated right now, right? But we don't necessarily want to hurt ourselves, right? Because we actually have a coherent sense of ourselves. If we don't, all bets are off. Anyway, I'm going to end there. I did want to make a plea for pluralism. That is, there's many different ways of working with borderline personality disorder, and I think that we need to study it more and do that. We can learn from each other. I was really impressed with the panel yesterday talking about crossing the alphabet divide and how thoughtful people are becoming about how these things fit together. Brandon beat me to a slide. He actually did it more classy than my slide here. I have been using this one for years, though. We need to become more integrated in our perspective. And this actually has to happen. I'll leave you with this provocative slide. This actually has to happen at the level of funding. This is actually all the funding for psychotherapy research on borderline personality disorder. The red is actually DBT research. The green is Marshall Linehan's DBT research. 97% of this funded psychotherapy research on borderline personality disorder is actually on DBT. 2 studies of TFP, our treatment development study, my F32. 1 study of MBT, one of Carla's students, so she now has a second student, so I guess that's going to go up a little bit. Greg Brown's schema-focused psychotherapy. Anyway, I'm going to end here because I see it's 1 minute.
How much money is that?
I'm sorry?
How much money is that?
Oh, more money than I'll ever see.
How much money is all this research on borderline?
Well, I don't know. 10 million is, I think, what on borderline in general. So it would be less than 10 million. That's, I guess, a year. So this is from 1985. So I don't know how much money. Okay, so let me end here. I don't know if anyone has any comments or questions or if I left time for that. Oh, sorry.
How frequently do you find that patients don't make it past the training?
That's a good question. We actually have data where we can look at that because I run a team, and every year the patients come in. We sometimes don't even get to the framing process, so it's not like they're dropping out because they don't like the frame. We find that they don't even get to the frame sometimes, so I wouldn't count that as a frame failure. But once you get to the frame, and let's say they don't buy the diagnosis or they don't buy that does happen. I don't think it happens as much as one would actually expect. I spend a lot of time on trying to set the frame in a very collaborative way, paying attention to patient acquiescence, gently confronting that, trying to come to some shared agreement, not being too rigid. I think one of the things that happens often in frame setting, in my experience, is people become rigid. So here's one modification I make, and hopefully Frank and Eve won't have a big reaction to this. I don't think so. I think I learned this from them. I don't necessarily require that the patient actually be involved in meaningful activity like a job or volunteer work. I need them to be committed to the idea that they want to go in that direction and we can work on it. If they don't want to work on it, then I'm not sure what we're doing. But I don't need and that's often a big misunderstanding. They're like, oh, you want me to get a job? I can't get a job. That's my problem. I can't work. You're trying to make me feel worse by asking me to work. Okay, this is going to take a while. But, we need to be on the same page that they want to do something that's meaningful to them and valuable, and we're going to work towards that. If that's the case, then I can set the frame with them on that. So I don't know if that helps. One small question. Mark and Joe, you can fight it out. Who goes?
Earlier, you were talking about dissemination and training. You talked about the amount of training necessary to be a competent TFP therapist. Could you comment on the differences in the amount of training that would be necessary to be considered competent in the array of empirical support?
Yeah, that's a great question. I'll actually say two things about that first. First, I do think that TFP, I've heard John Gunderson say this, so this is not my bias, this might be his bias, that TFP is actually the most ambitious of the treatments in terms of what it's trying to do. So there may be a cost in terms of the training in order to do that, and I hear what you're saying. You're saying, well, if there's these multiple treatments, let's go with what might actually be the most easily disseminated. Here's my impression, though. People will tell you that their treatments are more easily disseminated. I actually had a conversation a couple of years ago with somebody in this room where they talked about how they went to a weekend GPM training and now they're doing GPM. And so I go to a weekend GPM training, and I think actually Lois and John aren't here to tell me how I did, but I think I did okay. But what was really clear is that John didn't consider anyone in that room other than himself, and this was actually other people who were teaching at the level of being sort of independent GPM. And so when I talk to people in DBT, which definitely disseminates much better than we do, they're concerned about adherence and competence, and so I think it's a question of where do you draw the line? And John, John's actually been very inspiring in his model, and maybe it's something that TFP can think about too, disseminating, and Richard's actually done this, disseminating principles that people can take with them and integrate into their work. I think that's actually what I do in training graduate students. I see Mary Ann I'm using my one of my 3 channels. Okay, so Joe, I'll catch you later. Okay. Thank you.